staff, plus more effective and sustainable systems. Project Red principles improve safety and care quality, increase efficiency, and reduce risk through adhering to best-in-class standards. Project Red Solutions delivers training, implementation consulting, and measurement for better transitions of care. To learn more about Project Red Solutions, please visit our website, projectredsolutions.com, or contact any of us after this webinar. In our last webinar, Dr. David Renfro went through the practical organizational steps to implement Project Red in a healthcare system. Today, we are delighted to have Stephanie Sibicky, who will cover how Project Red principles apply in transitions of care among persons with cardiovascular diagnoses. It's one thing to know the principles, but it's quite another thing to apply them. How do we actually do this? This is what Stephanie will review. Dr. Stephanie Sibicky received her PharmD from the University of Rhode Island and completed a postgraduate residency at the Hospital of Saint Raphael in New Haven, Connecticut. She's worked in hospitals as a long-term care and academic pharmacist. She joined Northeastern University in 2015, go Huskies, and became the director of the Doctor of Pharmacy program there in 2022. Before I turn the virtual microphone over to Stephanie, I want to encourage the audience to add your comments and questions and observations in the chat box in your screens or under the Q&A. We'll also have time at the end of the presentation for questions, answers, and discussions. So please add your questions. Thank you, Stephanie. The digital stage is yours.
Thank you so much. And thank you for having me present on such a really important and pivotal topic relating to transitions of care, and with a slight focus in cardiovascular transitions of care and some of the complications that go along with that. I'm sure that a lot of the principles I'm going to talk about today could apply to different disease states. So I hope that even with your cardiovascular hat on, you're still going to take something away from this, regardless of if that's the population that you care for. So as Irving mentioned, you've got a little bit of my background, but I did want to just provide a little bit of context about why I feel really passionate about this topic. As mentioned in my bio, I used to work as a long-term care pharmacist before I worked for in the academic setting and in an inpatient, more general medicine type setting. And I found that in my experience there were a lot of issues from a pharmacy perspective when patients would come in and out of the hospital and come in and out of nursing facilities or rehab centers. And it started to spark this interest that I had in really exploring how pharmacists can be really integral in the transitions of care process. And through that discovery and through some of the research and other things that I've been involved in, we're trying to find what the best practice is and what can really apply to multiple patient settings. And so I hope today I can give you a little bit of my experience and some of the examples and projects that I've worked on and some of the data that exists, but also give you some thoughts about how pharmacy can be involved, whether you're a pharmacist or you work closely with them, and how we really can work together as a team to ensure the best transitions for our patients. So starting off, I couldn't be a true academic without some learning objectives for you today. So we're going to look at the Project Red based principles, discussing the pertinent issues for transitions of care for patients with cardiovascular conditions. And then we're going to look at some strategies to prevent medication errors and improve patient adherence as well, using some of those principles and some techniques that I'm going to pass along to you today. So maybe the first question, if you're not a pharmacist or you haven't interacted with a pharmacy team member, why should pharmacy be a part of this team? And I think that most of us in healthcare know that interdisciplinary teams really improve patient outcomes and satisfaction. There are a lot of studies, data, recommendations from federal, state organizations, from healthcare organizations that really influence and enforce that an interdisciplinary team is going to be the best for patient outcomes, regardless of what you're trying to treat. And we have competency statements now that we teach students in all different healthcare settings called the IPEC competencies that really reinforce this, and something that we're doing from an academic standpoint to ensure that our graduates are able to do this. But it comes from a really solid place of where interdisciplinary teamwork is beneficial. And as part of that interdisciplinary team, pharmacists as well as pharmacy team members, so I didn't want to just include pharmacists because there's lots of us out there. There's technicians, there's interns who are getting ready to be pharmacists, there's pharmacy residents, there's lots of different members of this pharmacy team. And we do provide a different perspective and a different angle than a provider or someone who works in social work or someone who works in dietary nutrition, someone who is a nurse versus a physician. And so what those are really focusing on the meds. We are your medication experts. If we don't know the answer, we will try to find the answer. There are lots of medications out there. I'm sure everyone's aware. And so we're really here to provide our expertise in the training that we have to make sure that medications are dispensed appropriately, that we're making evidence-based recommendations, that we're providing clinical data, chemical data. We're looking at interactions. We're looking at a patient's med list and from a holistic perspective. We're thinking about over-the-counter medications or herbal supplements and things that patients may buy on the internet. To be quite honest, sometimes we have to really do a deep dive to see what the patient is taking and how that's impacting their care. And so we offer a different perspective from a medication side. But I also feel, and maybe I'm a bit biased being someone who's an academic pharmacist, we really try to train students how to communicate effectively. There are multiple opportunities where pharmacists counsel patients in the community or in the hospital setting. We'll talk about discharge counseling in a little bit. But there are definitely techniques that we teach students on how to relay complicated information in a way that's more feasible for someone who doesn't have a background in healthcare or has very low health literacy. And so sometimes, even in my own experience working with my medical team, I will say, like, what if we try to say it this way? Or maybe you're using a tone of voice that the patient can't hear. And they're like, oh, I never really thought of that. And I'm like, well, these are some of the things that we teach students in pharmacy school to be really good communicators. So that's just a couple of examples. There are lots of other ways that pharmacy can contribute on your team. But I think the real focus today is how we really can improve those transitions of care for patients, especially who have lots of medications on that medication list when they're discharged. And in review, here are the Project Red principles. So we're using these as our backbone of our discussion today. And there are 12 principles listed here on the slide. And I'm sure that in every discipline, we all can play a role in these different principles. And even just looking at ascertaining the need for and obtaining language assistance. If a pharmacist is counseling somebody on a medication, we need to be sure that we're using a translator if necessary, or we have someone who can sign, or we have some way to communicate with the patient that's appropriate. But what I really wanted to do was focus, because I could spend a lot of time talking about each one of these, but I really wanted to focus on the several that are highlighted here. So a pharmacist can be involved, again, in all levels of Project Red principles, but really these 8 principles here are the ones that I'm going to focus on. So organizing the discharge outpatient services and medical equipment, correctly identifying medicine in a plan and an action plan for the patient to be able to take them, reconciling a discharge plan, incorporating national guidelines, teaching a discharge plan, educating the patient about their diagnosis, assessing the degree of the patient's understanding, reviewing what the patient needs to do if a problem arises, especially in the context of the medications that they're receiving, and then providing telephone reinforcement of the discharge plan. And so I will warn you, the next couple of slides, we're going to talk about some of the data. I can't go without highlighting some of the data and some of the projects that I've worked on. But that's what we're going to do next and see how these principles can be incorporated using a pharmacist there. So taking a step back, thinking about the importance of cardiovascular disease and transitions of care, many of us are aware that cardiovascular disease is the leading cause of death in the United States. It's responsible for many hospitalizations, readmissions, and mortality for our patients. So it's a very important issue. And breaking down the causes of death, you can see them listed here. This is from the CDC information. You can see that coronary heart disease is number one. We have stroke, heart failure, high blood pressure, and often these conditions come with lots of medications, right? And lots of overlap, lots of changes, lots of adjustments that need to be made. And so that's why really focusing on transitions of care for these patients in particular is going to be really important. And we want to prevent some of these readmissions. We don't want our patients to be seen in the hospital. We want them to stay home. We want them to have good quality of life and be happy, and we can contribute to that. On the flip side of this, I mean, there's a cost containment here as well. So we have to think about how much this costs the healthcare society, what it stresses on our system, and costs, indirect and direct, can be over $400 billion annually just for cardiovascular disease. And this offers a real opportunity for us to try to reduce some of those costs by incorporating some of the techniques I'm going to talk about. And again, like I mentioned, these conditions are often very complex. There are lots of providers involved, specialists, lots of medications involved, lots of in and out of facilities. And so there's lots of opportunities here for pharmacists to make a real impact and to streamline, help efficiencies, look for drug interactions, et cetera. And so we'll talk about some of those coming up. But I did want to say that there were two examples I wanted to pull that I felt were really good examples of how a pharmacist actually is involved in those transitions of care for patients who have cardiovascular disease. So this is a recent systematic review that was published, looking at upwards of 730 articles, where there were 5 that were actually included. One of the things that you will find if you've done any diving into the literature about pharmacist interventions is that they are very heterogeneous, lots of different types of interventions, different types of outcomes that are being reported. And that's partly on us as like kind of a downfall of this. We don't really have very strong randomized controlled trials that show that a pharmacist does this and this is how it improves outcomes. So we often are looking at some of these systematic reviews or these maybe smaller projects to see what the real impact can be. So in this systematic review, the identified interventions included providing patient education, of course, reviewing medications and optimizing medications, identifying drug-related problems, which can range from duplications to omissions to interactions to dosing issues related to adjusting for renal impairment or hepatic impairment, et cetera. Looking at adherence for patients' adherence and encouraging that, as well as incorporating lifestyle modifications. One thing that I find funny, and just as an aside, is that the team that I work with is often really surprised when I talk about deprescribing or getting rid of medications or alternating or choosing alternatives for their therapies like lifestyle modifications. And they're like, as a pharmacist, don't you want to add things? I'm like, no, we're trying to get rid of things. We're trying to make things better for the patient. We don't want them to be on drugs. So we are often very involved in the conversation about how to peel things back or incorporate some lifestyle modifications for patients. So in this study, they looked at both clinical and non-clinical patient outcomes. Again, this was fairly broad because of the varying styles and designs of the studies. So they looked at blood pressure, cholesterol, and glucose levels, and then looked at non-clinical like adherence, quality of life, and knowledge type patient outcomes. Looking at survey data, using some of the short forms that are available to assess quality of life, et cetera. And what this study found is that there was a statistically significant improvement in medication adherence, in quality of life on those surveys that were delivered, on patient knowledge of their cardiovascular disease in general. And then they also found from a clinical perspective, a reduction in the patient's cholesterol. And so these may seem minor, it may seem like a small number of studies, which it is, but there is significant impact here, right? And sometimes we're always looking for like the mortality benefit. We're always looking for the big intervention that's going to, change lives forever. But I like to focus on some of these smaller outcomes like quality of life, because for our patients, that really matters. I mean, mortality does too, but quality of life and making sure that the patient is understands and is aware of what's going on with them, with their condition, their family is aware of what's going on with their condition, can sometimes be a make or break on that day-to-day, in their day-to-day lives. All right. And then the second study that I wanted to present was actually one that I was involved in at the Brigham Women's Hospital. And what we looked at several years ago was a quality improvement project. I worked with a couple of pharmacy residents who were learning about transitions of care and kind of honing their skills in that area. They were specialists in that area. And we started a program that looked at patients who we consider to be high risk. So they were 65 years of age and older and had a history of acute coronary syndrome. But we also worked very closely with some of the providers to say, if you think someone is a good candidate for this program, then you can refer them over to us. And we had a very close relationship with the providers, both on the inpatient side and on the outpatient side, which we ended up yielding 118 patients for this initial quality improvement project. I will say that a lot of the patients that we saw were heart failure patients, in addition to acute coronary syndrome patients, because they just had a lot of medications and things that the providers really wanted us to work out for them. So what our interventions were gold standard medication history and reconciliation, both if they were in the inpatient setting, and then if we saw them in the outpatient setting, or vice versa, if they were outpatient, we would do this even if they did not have an initial inpatient admission that kind of followed through. So it would be either side. We would do an adherence assessment using multiple tools for that. We also provided coaching on access to their medications, if they had any difficulty with insurance coverage, if we could enroll them in any programs, coupons, grant programs that could assist with getting some of their medications. That was something else we did. If they were on the inpatient side, we would deliver their discharge medications to the bedside before they would leave, which was a program that had been started at Brigham and Women's Hospital for a while, and we just capitalized on that and was very successful in doing that. We did some transitions coaching for the patients as well, and then we provided follow-up, which is one of those Project Red principles that I mentioned earlier, that post-discharge follow-up. So we had that as part of this plan. And what we found over the 6 to 8 month period that we conducted this study was that we reduced hospital admissions for this patient population by 20%, which is one of those quality indicators that hospitals look at in order to be reimbursed. So we were able to achieve a significant reduction in those hospital readmissions. We found a lot of medication discrepancies. So averaging, I think it was like 4 to 5 per patient. And then most of them were cardiovascular medications, which we could assume, so a little more than half. And we had a very good acceptance rate of our recommendations to the providers when we made them. So over 80%, which is a really positive finding. And in general, from this project, we noticed that transitions of care pharmacists do improve quality and safety for these patients. And this project actually sparked a bunch of different projects at Brigham and Women's Hospital. And now we have medication reconciliation in the emergency department. We have pharmacists who focus on transitions of care for our cardiovascular population, which is a big part of the population we see at the Brigham. And so this really sparked a lot of conversation about the need for pharmacists to be on different units and provide these services. So I was really excited to be a part of this and worked very closely with the other pharmacists on this project. And we felt like, looking back, seeing the progress that it has made and the evolution that has come from it has really impacted a lot of the patients in a positive way that we see. So for the remainder of the presentation, I really wanted to give us some practical tips and suggestions on how to take care of these patients with cardiovascular disease. And what are some of the steps? What are some of the interventions that you can make or you can incorporate as part of your teamwork? So we're going to look at this patient case. And we have Aaron here, who's 55, and he has heart failure, hypertension, and atrial fibrillation, not an uncommon combination for a lot of cardiovascular patients that at least I see. And we learned that he started on several new medications, doesn't know which ones he should start, stop, or continue, that he has forgotten to take his medications occasionally, even though he has a supportive partner who does help with his medical care. So oftentimes you get just kind of a quick review of a patient's information. And as a pharmacist and in learning some of these important details in those 2 sentences below, I know that there's an education component that can be incorporated, and that communication is going to be really important here, both between the team, the patient, and his caregiver. So what shall we do? How do we even start this process? As a pharmacist, I tell my students, and I do this every day in my practice, always think about the meds. That's what we're here to do. So if you're thinking about, I don't know where to start with the meds. And so we're going to separate this into medication reconciliation and medication education, focusing on the reconciliation part at first. So what is medication reconciliation? We're comparing the medication list at every transition. This includes both someone coming from home to a hospital, to a nursing facility, or back home again. This also includes between units within a facility. So if they were in the ICU, intensive care unit, or they're going to the medicine floor, they're being transferred somewhere else, we need to be sure that the medication list is correct, that it incorporates all of the medications that are necessary, that if there are medications on hold, that those either continue to stay on hold or they are started again. And so there's lots of different factors to take into consideration, but we're really trying to make sure that the medication list is the best possible medication list. And we'll talk about that a little bit more on the next slide. Another thing that we do while reviewing medications is thinking about evidence-based treatment recommendations. So it's not just comparing one list to another and saying, it's lisinopril 10 here and lisinopril 10 here, and we check it off. It's also going through the process of, are all the medications necessary? Do they have indications that are missing medications? Are there medications missing indications? What questions do I have? Why are they on this? Why did they stop taking this? Those are the types of things that we are looking at as a pharmacy team member to ensure that we aren't missing anything or that we're providing the utmost patient care as possible. I will sometimes say that pharmacists are sometimes Sherlock Holmes. We don't always have all the ins and outs. We haven't spent as much time as the providers maybe have with the patients. We try to, but we have a lot of people that we need to see. So in focusing our time, we're often looking at a med list, or we're talking very briefly with the medical team. And so we often have questions that come up, and we have to do some investigative work to figure out why things are the way they are. As I said previously, pharmacists usually, if we don't know the answer, we can often find the answer, or we know somebody who can find the answer. And that is true here too as well. So in completing a medication reconciliation, there's often lots of questions, lots of people involved. And so we're putting on our Sherlock Holmes cap, getting out our magnifying glass, and trying to figure out what the real answer is to the question that we're trying to solve. The second part that we'll be talking about is education. This is one of those Project Red principles as well, really involving patients and caregivers in the conversation, but also the team. There are some medications that require different laboratory monitoring or follow-up, and most of the time providers are going to know those, but it's possible that they may miss something. And so knowing most about the medications, being that medication expert, we can really say, oh, we need to make sure that we're following up on this potassium level or on this digoxin level or their INRs if the patient's on warfarin or something of that nature. So we can be really vital in doing that. Thinking about the patient's diagnosis and assessment of their understanding of their disease state, as well as the understanding of their medications and what they're used for. This is a really pivotal part of patient counseling and doing discharge counseling as well, to be sure the patient understands, when I give you this medication, it's for your blood pressure. You may not feel the effects of this, but that's to be expected. Do you understand that this medication is for your, because you had a heart attack, it helps with your heart rate. It helps with your, to make sure that your heart doesn't, remodel or restructure in a strange way. We can really provide some of that information and also confirm with the patient that they do understand what their conditions are and what their medications are used for. Another pivotal part of patient education is letting patients know what the problems could be that arise and who they should talk to. This is particularly important for side effects and really opening those doors of communication. We'll talk about that in a little bit. And then again, reviewing that discharge plan and reinforcing some of the items that need to be discussed as the patient nears discharge and even after they're discharged in a follow-up call. So the medication reconciliation process and transitions of care process is very complicated, and there are lots of different components to this that I really want to raise as part of its definition. So this is an image that's adapted from an old article from the Annals of Internal Medicine, but it still holds true today. And so we can see in the middle, towards the left-hand side, the different areas that a patient may transition from home to a healthcare facility and then home again, or from one facility to another, back home, back. I mean, they can go back and forth through this. It's not one arrow, although the arrow is pointing to home. That's usually our goal. It can really go back and forth. And so what we need to do when we're trying to come up with the best possible medication list or the best possible history for this patient is gather all the information, putting on that Sherlock Holmes cap and saying, where am I going to get all of the data points to really come up with what this patient should be taking and what they have been taking? So that can include, first and foremost, doing an interview with the patient if they can, and their caregiver or their family. I'm a huge advocate for patients carrying med cards or bringing a list of all of their medications with them if they're going to any healthcare facility, having that available somewhere. There are programs that have like magnets that you can stick on your fridge. There are more advanced like app-based programs that can provide this as well. But again, it's really about, is the information up to date and is it accurate? So finding different data points is really what's going to help with that. So looking at their the interview with the patient, looking at their medication list, if they can bring in the vials of medication that they receive, that gives us a lot of information, both what medications they're taking, but also where they're getting them, who's prescribing them, how long they've been on them. And then we can also figure out which pharmacy that they use, which leads to our next place of information, medication databases and pharmacies. This is one of those things. I have an index card that has a list of a lot of really important phone numbers. Finding all of the patient's medications can sometimes be very challenging, especially if they're unable to tell you where they fill their medication. So we have to think about community pharmacies, mail order pharmacies, pharmacies that are embedded within hospital systems or in doctors' offices, and taking all of that information and compiling it into a list. I can't tell you how many times I've had a patient who fills only some of their medications one place, and then they go another place for other medications, or they get a better deal at a different pharmacy. And so we really have to take all of that information and try to find as much of it as possible. I will give a little hint here that if you are performing a med rec and you are calling a pharmacy, you can ask them sometimes to do like a system-wide search for the patient, depending on how busy they are. So they can pull up all of the medications that that patient fills within that pharmacy system. It does take a little bit of time sometimes for them to pull that up, but you can ask. So like, does this person fill at a different pharmacy? Can you see that? Is that information available to you? So sometimes they can help with that. The other place we can look is in their health records. So calling their provider's offices, they may see multiple specialists. They may have one primary care that has all of the information, but it's good to confirm. And oftentimes this step is missed because we rely a lot on computers and systems and different databases that we have access to, but that's really an important component here. So hopefully using those information resources, we can get that best possible medication list or history. And then again, as that patient transitions between different units in the discharge, in the healthcare facility, we do want to be sure that everything is where it needs to be, that we aren't missing anything, that as a patient is nearing discharge, we're restarting some of their home medications to be sure they can tolerate them. And then come up with this best possible medication discharge plan. So I like to be involved in this stage with my patients in the hospital because sometimes the patient wants to go home and it's quick and it's fast and they want to get them out by noon, and we're not always like on the phone with them calling, which I wish they'd call more times. But what I like to do is if I know that a patient is nearing discharge, I start that process maybe 2 or 3 days before they're going home to be like, what are their home meds? Are we continuing them? Do we need to restart them now? Any changes? Can we talk to the patient about what those changes are going to be? And that really helps not only the team come up with the best possible medication discharge plan, but also lets the patient know what they're going to expect when they get home. So the different components to that includes that discharge list. If they have any prescriptions that need to be sent to a pharmacy, this is where that like meds to bed program is really helpful because we can often fill them downstairs in our outpatient pharmacy and then have the medication sent upstairs. So the patient has everything they need before they get discharged, but that doesn't always happen. So making sure that whatever pharmacy they choose to use has the right prescriptions, that they've all gone through insurance. So that's not a barrier, or that we identify it early on, and making sure the patient is aware of what's starting and what's changing. Looking at the physician discharge summary should also have information there that we can be really influential in helping to, provide, do we start, stop, or continue some of these medications or change them? And then what is their schedule? So a lot of the electronic medical records now have this in the systems themselves, and you can print out a medication schedule. I do like printing my own and going through it step by step with the patient, or asking them what's going to work best for them. And we'll talk about that a little bit more in the patient education slide. And then all of this information really needs to be communicated to the patient, to their providers and caregivers. If they're going to a nursing home or a rehab facility, making sure that this information is passed along in the most efficient and effective way possible. This is not an easy task. If there are systems in place that don't speak to each other, if we're looking at paper, fax machines, emails, things of that nature, there is opportunity for there to be information that's lost or transcribed inappropriately. And so there's a lot of responsibility on all of the members of the team to ensure that this process occurs smoothly, and pharmacy can be a part of that and should be a part of that. And so we can talk a little bit more about that later. But that's a really important piece here, is that communication. So let's look at Erin's medication list. So we can see a few things here. And as a pharmacist, I already am noticing a couple of things like doses being scratched out, and thinking about how often things are being administered, like the metoprolol is being given morning and night. They're on aspirin. They're taking an albuterol inhaler. And so knowing that this patient came in with 3 past medical history, cardiovascular diseases, I'm already asking questions. Why are they on omeprazole? Why are they on albuterol? And then what we did is we can talk to the patient, and we'll just assume that we did. And these are some of the questions we asked. So we asked him to describe what he's taking. He confirmed what he was taking. He tells you what these medications are for. So lisinopril and chlorthalidone were for his blood pressure. Apixaban and metoprolol were for his atrial fibrillation and clots, is what he said. He wasn't sure why he's taking aspirin. He's taking his omeprazole for heartburn, and he only uses his albuterol when it's cold out. So now I'm getting more of that information. So I'm thinking already, okay, we have a couple of medications for blood pressure. he looks like he's on the appropriate things for preventing stroke, for atrial fibrillation. He's on rate control. And then we have some questions about some of these other things. Does he have an underlying condition like gastroesophageal reflux disease, or is he just taking omeprazole because most people are on it, or they started it in the hospital and then they never discontinued it? So we have some investigation that we would need to do. So as a member of the pharmacy team, I would call the pharmacies that he's identified as places he fills his medications. And this is the information I get back. So they confirm his fill history on all of the medications except for aspirin, which is not surprising because aspirin is over the counter. And so it doesn't often hit their insurance. It doesn't need to be filled by the pharmacy staff. So, but we do realize that he is filling things. He is filling them on time, and the history is confirmed. Now, again, this is one piece of data in a broader scheme of things. Just because a patient fills medications and picks them up does not mean that they are taking it. So that's where a critical conversation needs to happen. And with Aaron, we've talked to him and he says that he does take them, but he does forget them sometimes. We also learned that his albuterol was filled 6 months ago. So that's just another piece of information to say that maybe he's not using it very often. So the medical team wants to start him on a slew of new medications. And these are evidence-based medicine recommendations for his heart failure, including some of our newer agents like sacubitril, valsartan, spironolactone, empagliflozin, and furosemide. Those are for his heart failure. And they want to change his metoprolol to metoprolol succinate, which is the longer acting version for 50 milligrams a day. So I'm going to ask, are there anything else that you see here? Like, what are some of the concerns that you might have for this patient looking at his med list now and then thinking about the things that we're going to change? And we'll talk about that. So the first thing is that as a pharmacist, I'm looking at what are the additions, anything we can discontinue, change. How do we transition patients to these different medications? So sacubitril valsartan is one that does have a drug interaction with the lisinopril that he's on. So we do need to ensure a 36-hour washout period from one to the other. So that's going to we're going to have to counsel the patient on how to do that and counsel the team on what the follow-up would be for that. In addition, that medication has some diuretic effects, and maybe the team is unaware of that. So we might want to hold off on his other diuretic like furosemide to see his effect from the sacubitril valsartan before starting another medication, which could reduce some of his fluid. We definitely would want to increase monitoring for that, like their patient's weights, and if they're experiencing any types of side effects while starting those medications. Other monitoring would be for electrolytes like potassium, looking at the patient's kidney function. A lot of medications here are starting that can cause hypotension or falls. So making sure the patient's blood pressure is staying at the appropriate goal would be helpful. And then thinking about costs, this comes up a lot for heart failure patients now. We have newer drugs like sacubitril and empagliflozin, but they are branded products. And so we do need to be conscious about adding multiple new agents, what the cost containment is, what considerations we have to think about. Some of my colleagues will often negotiate with patients and say, if we could pick one, would you pay for one? Maybe we can do that and we can decide what the best one is for starting based on what the patient can afford. So some other things to think about. Other medication changes. So switching to metoprolol succinate does have evidence-based mortality benefit for patients with heart failure. It is also going to help with the patient's atrial fibrillation, but oftentimes switching from a twice-a-day metoprolol to a once-a-day metoprolol isn't a one-to-one conversion. And so we do need to make sure we're monitoring the patient's heart rate changes because they do have atrial fibrillation. So keeping a close eye on that. And then the last thing for him that I notice is there's a potential for polypharmacy here and his anticoagulation. So he was on apixaban and he was on aspirin. And there is noted risk for increased risk for bleeding when the two are together. I noticed that his dose was crossed out and lowered. So he was on 5 milligrams, but then was changed to 2.5. So we need to think about if that's appropriate. There are certain dose considerations for apixaban, and if he doesn't meet all of them, he's going to be not benefiting from the stroke prevention if it was decreased because they were worried about bleeding? Did he have a bleed in the past? These are some of those questions that I would be asking. And then just even taking a step further, like, why is he taking aspirin? Is it for primary prevention, which is not something that's recommended anymore? So maybe it's as simple as just discontinuing that and then continuing on his apixaban. So that's just a quick example, but I do want to summarize some of the considerations for evidence-based treatment recommendations. So considering polypharmacy, especially in cardiovascular disease, as I mentioned, a lot of overlapping medications. So one example that I see very often as an inpatient pharmacist is patients come in with hypertensive urgency or emergency. So they have really high blood pressures that could potentially cause damage to their brain. And we notice that they're on like 4 or 5 antihypertensives. And the team will be like, well, the patient's either not taking them or they're not working. And so as the patient, we start to stabilize them. We start to reinitiate some of their blood pressure medications from home, but I often am cautious. I'm like, whoa, stop. Like, let's do one at a time, because the patient probably wasn't taking all 4 or 5 at home. So we need to do this gradually and slowly. And maybe they don't need to be on all of them. So certainly something that's just an example to think about, but we do need to consider multiple medications for the same thing that can increase risk for side effects and poor patient outcomes. We also need to look at drug-drug and drug-disease interactions. Pharmacy can really help with that. And making sure we're optimizing medications appropriately and looking for pharmacokinetic interactions and pharmacodynamic interactions. So, are drug levels being altered because there is a drug-drug interaction? Are we increasing their risk for toxicity? And then if we have multiple medications that, for example, cause hypotension, we're increasing the risk for falls or for patients to have low blood pressure. So we need to consider those pharmacodynamic interactions as well. And then this is one of those it's like a mantra. It's like the pharmacy dogma in some ways. I call this the Sibicky square to my students. I did not make it up, but I like alliteration. And so these are the components to the Sibicky square: safety, efficacy, cost, and feasibility. So these are the factors I often consider when starting a medication, taking medications away, reviewing pros and cons of therapy, thinking about safety first. What are the side effects? Is this going to impact the other disease states the patient has? What are the drug interactions? Is this medication on the Beers criteria? Is this patient an older adult? Are we going to see benefits based on their life expectancy or their prognosis? The efficacy of the medication. Is it better than or just as good as other things that the patient's on already or what's available? Does the patient fit the criteria for the studies that the medication was evaluated in? Again, thinking about cost. So what is the patient's insurance coverage? Are there alternatives available? Do they qualify for coupons, grant programs, any type of assistance from the government? Medicare, Medicaid, thinking about their just in general socioeconomic status and if it's feasible for them to be able to afford their medication. And then the last part is feasibility or adherence. So is the regimen so complex that the patient isn't going to be able to take it? Are they, 20 miles from a pharmacy and they don't have a car? And so it's really hard for them to get to the pharmacy. Maybe we have alternative ways that we can get their medications to them. And so we have to really think about those and consider all of these patient factors and stressors that they could have in their life that could impact not only how they take their medications, but also how that impacts their disease state in general. So transitioning quickly to and kind of following up on the medication education component as we close the last few slides here, really reviewing that discharge plan and reinforcing what we want the patient to do. Having their family be involved in that process is really helpful, and taking lots of notes, using a highlighter, asking the patient how they want the information to be displayed to them. Using the teach back method, this is one of those Project Red principles of making sure the patient understands what their disease state is and what their medications are. We train students to say something like, just in case I've missed something, can you tell me how you're going to take your metoprolol? Can you tell me what your apixaban is used for? And hear what they say back to you. It gives you a really good sense of their understanding and also allows you the opportunity to fill in some of the gaps if you feel like they've missed something critical. I use this also like as an aside with my significant other, because sometimes I don't think he understands what I'm trying to portray. And so just in case I didn't miss something, can you tell me what I meant by this? So it can be used in other settings outside of patient care. Making sure that the patient understands their plan for follow-up for labs, monitoring side effects that they could be experiencing from the medications, being sure that they understand to speak to someone if something is going wrong. The pharmacy also is a place that people frequent fairly often. They come either every month, every 3 months. Maybe they're picking up other things and they can just swing by the counter and ask a question. Knowing that pharmacists are available to help in the event that there's something going wrong or that they're having these side effects that they don't expect. Or something that I see actually more common is that people are having a side effect, they don't tell anybody. And so they just say like, I am going to stop this because I don't feel the effects of this, or I'm going to stop this because it's causing me to have, I'm really dizzy all the time and I can't tolerate it, but they don't tell anyone. So I always say, go to the pharmacy, ask the pharmacist if there's an opportunity for them to intervene or talk to their provider, find out if there's something else that they can do. But really coming up with that plan of what to do in the event they are experiencing those side effects, and then having a clear plan about what to do. I often think about red flag situations as well. If they're having an allergy, if they need to call 911, they need to know when they need to do that, and who they should contact, and really having that written somewhere so that they can refer to it. All right, and then finally, just a couple of other tips and tricks that you can think about in caring for patients through these transitions, making a schedule and planning for patients. There was this website, My Med Schedule, that I really, really liked, that I used to use for all of my patients when they would be discharge counseled. And it's now an app. And I think about my older adult population, and they're not always jumping to go on an app to plan their medications. Some of the younger, older adults, some of our baby boomer type generation might be more amenable to that. But it's a really great app that has the ability to enter all their medications. You can do that with the patient. You can review what their side effects are. You can review what they're used for in that app. It's a really great tool. The AHRQ also has a printable schedule that you can use. There's a link here. I'm sure the slides will be made available. You can also Google AHRQ printable medication schedule, and you can download it and you can fill it out with the patient. I find that that's really helpful to do. I often, depending on the patient themselves, I can have them fill it out, and I'll just like watch them and work with them together on it to see that they like understand what they're taking when they need to take it. You can understand that in a hospital, sometimes patients aren't willing to do that because they're not feeling well. But I have no problem doing that. It's a great way to get students involved in the process as well. And as part of the education, we want to make sure that the patient is aware of what the new medications are, what they need to be starting and stopping, and what the common side effects are. So here's just some based on Aaron's medication list. So thinking about his weight monitoring for volume overload, when he needs to have his scheduled lab work done, thinking about blood pressure checks. He can do those at the pharmacy if he'd like, or visit his primary care. And again, really emphasizing that communication is key. So if something is not working, or you are contemplating stopping a medication because of a side effect or some reason, just letting the pharmacist know that that's something that you plan on doing, letting your provider know, and making sure that everybody is aware of the process and what the solution to that is. And then those red flag symptoms. So if you experience shortness of breath, bleeding that doesn't stop, blood in the urine or bowel movement, calling their provider or visiting the emergency department or an emergency center would be really important. So those are some of those red flag signs for Aaron that I would counsel him on. So I hope that example has been helpful. And we're just at about time to answer some of your questions, but some key points that I hope you can take away from today is that a pharmacy team member can be really integral in the interdisciplinary team. We provide different levels of service, maybe different ideas, definitely contributing to the overall care of the patient to ensure safe transitions. Cardiovascular disease in particular is one of those conditions that can be considered high risk because of some of the issues that we talked about, overlapping medications, increased risks for side effects, polypharmacy, et cetera. And then those real Project Red principles that we can reinforce as being a pharmacist, including getting a thorough medication reconciliation, using some of those evidence-based treatment recommendations to improve care, and providing appropriate medication education. And all of those things together in working with the team can really improve some of those transitions for those patients. And with that, I think we are ready for questions.
Thank you. Thank you very much, Stephanie. What a good job.
You're welcome.
You ran through it, you got it done, and we have some questions here.
Fabulous.
Okay, so got a few here. Many people are snowbirds, splitting their care between providers in at least 2 different parts of the United States, sometimes even internationally. How does this situation impact transitions of care? Are there hints or suggestions for coordinating care across state borders?
That is a fantastic question and one that comes up a lot. So I will say that I think that, and this is probably true for many people, the best thing that you can do is you can have one spot that has all of the information, and that is transferred with that person. Now, it seems simple, but it's very complicated to do that. I have some experience when I was a pharmacy student in this phenomenon, because I was working in a pharmacy and all we did for like the entire month of September was transfer prescriptions in and out because we were in a vacation type setting. And it's really challenging. It's important, again, that there's a structured list, that there is notification of where this person is going, right? So knowing that, like, if it's something that happens fairly common, right? Like if someone, like, I always go to Florida for the winter and I always come back to Boston for the spring and summer. Having a good communication plan between those 2 places, both with the providers as well as the pharmacies that the patient uses, is going to be really important. It is much easier if the patient is filling medications in a pharmacy that, like, it's the same pharmacy, like a chain type pharmacy, that facilitates because they can look things up a little bit easier between the 2, but that's not feasible for everyone and based on their insurance or what they prefer. I'd rather you see a pharmacy that you want to go to than be like forced into one. But I think that does facilitate some of this. But really making sure, again, it's that communication plan, and it's having the forethought to say, like, this is where I'm going, this is who I plan to see, and making sure those people communicate with each other. Unless we're on like a national health service or a system that everyone uses the same, it's going to be very challenging to do that with technology. Although I will say that, like, there are some apps and there are some things that have come out that do help facilitate this. But those come with pros and cons, which is probably a conversation for another day.
Well, that's you've really responded to the question. And of course, what's behind this is all the different formularies. So the formularies in the hospital are different from the formularies that the home health agency might be using, which is different from the formulary that the skilled nursing center uses. So communications, as you were saying, and having health consumers be more responsible for their own care. You highlighted that at the top. You said having it all in one place is really the best situation.
It is, yeah. And go ahead.
Next question. When a patient is discharged from the hospital, this is a tough one.
Oh.
Whose job is it to teach them about their medicines? How can we do a better job with this?
That's a great question. I think it's everyone's job. I might be a little bit, I know that this does come up a lot, because it'll be like, should pharmacy do it? Should nursing do it? Should the providers do it? Should, like, who is responsible? Who is the responsible person? And it's going to depend per the institution. I don't think anybody does it better or not as good. Like, I think that everybody does it in their own way, and they all do the best job that they can do. I don't think anyone goes into a situation where they're like, I'm going to counsel this patient and it be like 50% effective. Like, I think we all are contributing in our own ways. I will tell you that I think it's the team approach, going in, knowing what you need to say. Whenever I do discharge counseling, I always ask the nurse who's taking care of that patient, what have you talked to them about during their stay? Have they had Lovenox counseling or enoxaparin counseling, or have you talked to them about some of these new meds? Because they do. Nursing does a lot of day-to-day communication with the patient and prepping them for discharge. So making sure we're all on the same page, and that information that's being given is the same between all of the team members. It doesn't matter whose job it is, because you're all coming at it from the same perspective. You're all using the same information to give to the patient. I will say, like, I will trade off. Like, if I feel like the nurses are very good at like glucose, glucometer training, insulin training. Sometimes I sit in with them and we can kind of bounce off of each other. So I think it's everybody's job. I think we can all work a lot better to ensure that we're all on the same page. And I would encourage anyone who is involved in discharge counseling, if you have the time, to spend time with another discipline and show the patient that there is a team that's taking care of them, that is going to, put in little tidbits of information that will be helpful for them.
Terrific. And in the last webinar, for the person who asked that question, in the last webinar, Dr. Renfro actually covered that. He actually covered how to design the teams so that there is that information sharing, that information coordination. I think we have time for one more.
Sure.
I work in a nursing home, and most of the time when patients arrive from the hospital, their medication orders are incomplete. And there are also frequent contradictions among the orders. What can we do about this?
Yes. As someone who used to work in a long-term care pharmacy, I concur. This is complicated because there are a lot of steps to ensure that a patient transitions out of the hospital appropriately and transitions into a facility appropriately. It's not lost on me that sometimes the discharge paperwork from the hospital is incomplete, and that in the nursing facility that causes a lot of frustration, because it's sometimes hard to find who to talk to. It's sometimes hard to piece all of the information together. I know that there are pass-off conversations that do occur between nursing, between some of the folks who are involved. I know that it's a very challenging situation unless you're in the same system. I was lucky when I was working in long-term care at one point that the patients coming from the hospital, we had access to the hospital system, so we could see what was going on. But that is not feasible in every case, and oftentimes is probably the exception than the rule. And so what we can do about that, I think that, really having a critical eye on what is going on, asking those questions, figuring out who you can contact, who the best people to contact are, voicing your concerns, because that's the only way things will change. I mean, sometimes you feel like the squeaky wheel, but voicing your concerns, if you're seeing something that's a pattern over and over again, that really warrants the hospital making some kind of change or the facility making some change. Getting team members involved. In many nursing facilities, there isn't a pharmacist who's sitting in the facility with you. Calling them on the phone, being like, I have this medication list. It doesn't look right. Can you give me what your questions are? Can we work together to talk to the provider? Maybe you can get some leverage, or you can figure out how to contact them. Really working as a team to try and figure out what is the best list. Sometimes decisions have to be made, and I understand that. And providers that work in facilities will sometimes be like, no, this is the decision that has to be made. We need to care for this person. We need this medication. And that's okay. Having that plan for follow-up and monitoring is going to be really important in those situations. But I really think the best thing we can do is communicate and work with each other to see if we can figure out how to make this the best we can, and report those concerns back. Because the system won't get better unless we do that.
Unfortunately, there's a lot of that reporting that just sounds like squeaky wheel stuff.
I know.
So here's a last one. We have time for one more quick one, although
Sure.
I'm not sure this is quick. We're in an assisted living, they say facility. I'm going to call it a community. We're in an assisted living community, and we want to keep our residents when they get back from the hospital. Of course you do. How can we use your advice and Project Red to help keep our residents here?
Like in the ALF.
Yeah. So the patient gets discharged from the hospital to the ALF. The ALF wants to keep them in the ALF. They don't want them leaving and going back to the hospital or going to a SNF or elsewhere. So how can an assisted living residents, understanding that they're all different states, I don't know where this person's from, there's all different states and all different state regulations about the ability of the staff to interact with the resident. How does an assisted living residence pick up this challenge?
Right. Which, I mean, you highlighted, Irving, a lot of the complications here, and depending on what the services the patient has or the resident has, right, it depends on how involved everyone is. I would say that things you can do to keep your patient in your ALF, if you recognize that they are somebody who might be high risk or somebody who has trouble based on interactions, whether it's someone like who's coming in for housekeeping or, you know, like kind of light nursing services, or depending on like the level of care, whoever is interacting with this patient, even if it's at dinner time, whoever is interacting with this patient, if you see something, bring it up to someone, bring it up to an administrator, bring it up to the patient and their family. Maybe they qualify or might need a higher level of care, which could incorporate having more nursing care or having pharmacy come in to look at the list. Most of the patients who live in ALF, well, some of them will have their medications filled in a community pharmacy versus like a long-term care pharmacy. And that does adds more people to the conversation, but making sure there is that open line of communication with whoever is filling their medications if it's a medication related issue. So again, I think it comes back to like communication. It comes back to being observant and speaking up when you see something that you think could be troubling for that patient. So I know we're at time. I won't go any more into that, but that was a wonderful question.
Thank you, Stephanie, for an excellent presentation. And thanks to everyone for attending, and look for an email from Project Red Solutions with the link to the recording of this program and others. We encourage you to share these resources with your colleagues whom you think may benefit. And be on the lookout for more programs in 2024 when we'll expand the topic of care transitions to the international stage, examining how transitions of care are managed in other countries and between countries. Be on the lookout for these alerts in your email. And please visit www.projectredsolutions to access today's program and our other resources, and to learn how Project Red Solutions can help you take advantage of the Project Red principles through training, implementation, consulting, and measurement for better transitions of care. Thank you, and have a terrific rest of your day.
Thank you.